Good morning, Shante. Since I can't be at school in the morning, I have an appointment I have to keep, and we don't really have anybody else available. I thought I would record this. I will let you know that it's available. I hope you read your emails and see this and don't actually come in. Chapter 25 and, um, uh, or rather, Chapter 26, even though this says chapter 25, it's actually chapter 26, is the medical care system a public health issue. Um, uh, Much of the medical care system involves things that affect the overall public health, like immunizations, prenatal care, baby care, and other issues as well. Um, when is it a public health responsibility? Well, we do have the issue that we are preventing the spread of communicable diseases. Vaccination does that. Monitoring does that. The provision of emergency services is a public health issue. And then hospitals uh, are required to provide care for any life-threatening condition. Theoretically, veterans can get care in the VA system. That's been problematic at times, but it's getting better. Um, and of course, the law states very clearly that prisoners have a right to medical care. Um, Paid for, this first statement here, most Americans get health insurance through employer. That may still be applicable as a statement, but it's not quite the same um, as it has been. Um, the laws exempt employers from having to offer, especially small to medium enterprises, businesses with under 500 employees, from having to offer health care to their employees if they work for less than a specific amount. I think it's about 32 hours a week, which is why so many people will be given a job offer that will cover 30 hours a week, because then they're exempt from being provided those kinds of expensive benefit. Charity care is indeed a long tradition in the United States. Starts with the establishment of the first hospitals in the middle of the 18th century on the East Coast. We have public disease clinics, community health centers. The whole issue of Medicare for all, um, the the provision for the Affordable Health Care Act was in response to the difficulty and the opposition to any sort of expansion of Medicare to wider populations. Medicare was actually passed in 1964. I remember the time very well. It was a tremendous fight. The AMA and some other organizations were fighting it tooth and nail. Many doctors, however, did not agree with the AMA's stance, and it actually cost the AMA some membership. That's changed now, but nonetheless, Medicare and Medicaid appeared and provided for care, the Medicare for Americans over 65, and Medicaid for people that were unable to afford any other form of medical care and could means test into that system. 20% of the US population under 65 uninsured, that may not be as true, although certain efforts to get the Affordable Health Care Act or the Affordable Care Act nullified may accelerate that number quite a bit. The ACA actually reduced that number some, but still there are people who are uninsured. Um, there are a lot of issues Um, Medicare is part of the Social Security system. The age 65 was actually chosen when Social Security was set up in the 1930s, um, based on the average lifespan of Americans being actually a little bit less than 65 years of age. And so the thought at the time was that mostly this would not be a big problem. Um, we'll see. Part covers hospitalization. Part B, which has a so-called voluntary monthly premium, but now not really, um, looks at doctor's bills and outpatient costs. And we now have a drug plan that was actually resisted by the pharmaceutical industry very, very vigorously, and they managed to lobby their way out of Medicare. And within 10 years, they were regretting it because um, the the cost in medicine skyrocketed because basically doctors could charge what they want. And all these other things occurred, and the pharmaceutical companies um, realized that they were out in the cold. But it took another 40 years or so, for 30 to 35 or so years, for for drugs to actually get into it. So we also have the SKIP program for the Children's Health Insurance Program as well. Um, we both know this already. States licensed physicians um, and hospitals, and they are responsible for maintaining that. Um, Medical care has had lots of ethical and legal issues over the years. Roe v. Wade and the whole abortion debate is something that has gotten back into the news, with current fears on the part of many people that the current makeup of our Supreme Court could end up nullifying or completely or severely restricting the applicability of Roe v. Wade. Um, we have lots of other these things, the assisted suicide stuff, the story of Jack Kevorkian, known as Dr. Death, who believed that if patients wanted to die, they had a right to die. Um, this has led to a number of states passing right to die legislation. Um, and uh, the uh, the effect has been rather interesting. Much of this came about because of some very high profile cases of patients who were clinically dead. They had no brain activity, but the machinery could keep their shell, their bodies functioning, and artificially alive, as long as they were fed, as long as they were oxygenated, and as long as their hearts were kept beating, even if there was no brain activity. Um, Most of us would agree, I think, that if your brain has no activity, your body is dead, and artificially stimulating it to stay alive has little in the way of good um, uh, rationale behind it. Um, is there an obligation to provide futile care? Futile meaning care that will not result in a good outcome for the patient. Many of these cares are uncomfortable. They are hideously expensive. This is why we have DNRs, why we have living wills, why we have rules that allow us to tell the medical profession that in the case of our uh, extreme debilitation, um, that we should be allowed to simply pass on. No extreme or heroic measures be used to keep people alive. Um, so we have the handicapped infants. We have um, we have low birth weight births, low birth weight babies. Low birth weight in this case meaning under 3 pounds. Just read an article about a baby that just weighed over a pound that now has gone home from the NICU and from the hospital. Um, and I look at that and I think a baby that small isn't very well developed, and much of that development occurs in the most ideal environment that we have, which of course is the mother's womb. Um, and expecting this development to occur outside the womb with the intervention of lots of medications and agents to theoretically mimic what goes on in the womb, we have no idea whether that's very effective. It's very expensive. NICUs are some of the most expensive places in a hospital, and the outcomes are often very poor. One of our babies, our second daughter, spent the first couple of days of her life in a NICU, and she was, thank God, the healthiest baby there. Thank God for her. Heartbreaking for the others, however, and some of them did not come out of that unit. We've got other things in terms of resource allocation, not just things like dialysis. These things called God committees. This was a nice soundbite invented by people opposed to it, which was basically claiming that these groups of people, which are highly professionally trained and generally very compassionate people, who are making decisions about how to make best use of scant resources. The kidney dialysis is a very uncomfortable, time-consuming process that needs to be done several times a week on a patient. It's very expensive. It's generally paid for by the government. Transplantation has gotten to be much more, I won't say routine by any stretch of the imagination, but it has gotten to be much more highly successful. Um, but transplantation in general has multitudes of problems. Immune suppression over a long period while the body basically makes itself capable of supporting the transplanted organ, just a lot of these things. There's also a shortage of organs, especially in this country, where we have to opt in. You have to literally say, yes, you will allow your organs that are usable to be harvested and made use of upon your death. Um, this There are certain religious groups that, of course, are absolutely opposed to this. That's certainly their right. And there are other groups that are opposed for psychosocial reasons, meaning you can't tell me what I'm going to do. So in this country, we have an opt-in system. In parts of Europe, we don't have an organ shortage problem. We may have problems with finding the right match, but the shortage is solved by you have to opt out. You have to make that choice to take yourself out of the transplant, because when you get a driver's license, and presumably, and in Europe, they're a lot more restrictive about who gets those. But when you get a driver's license in Europe, you're automatically put into the system unless you specifically opt out. And what we know from all sorts of sociological research, people will not opt in, They just won't bother if it's an opt-in system, but they also largely won't bother to opt out in an opt-out system. So we could do something like that here if we could get it past our incessant personal freedom issue. Another major question here to go back up to the abortion issue that's once again coming on board. And it really is about, to some extent, freedom. It's also about the intersection of religious thought as to what makes a human, or others. And so it's a really thorny issue that keeps coming back. It comes back about every 15 to 20 years in my experience. Another one is the assisted suicide issue. This is another current issue. I know, I don't remember the result from the last election, but I know that was on the ballot here in Colorado. Assisted suicide, I think, but it requires multiple practitioner signatures, and very careful procedural issues. Having been through a situation where where my niece's father had a 30-year history of MS, had been in sometimes excruciating and totally disabling pain for a good portion of that 30 years, finally gave up and committed suicide. I can't blame him. It's not my bag, but I can't blame him for that, because I know, we knew him well. I know he was suffering. So I can understand the desire, but it has to be something. But he just did it himself. It was not an assisted suicide. There's a point at which some people have decided that life simply isn't worth continuing, and that's a real ethical issue, because in order to have an assisted suicide, a doctor has to provide the drugs that will take care of it, that will actually allow the patient to end their life. And that's a real thorny ethical issue. A lot of physicians won't do it. And, I can't blame them. I mean, everything they're taught is to keep people alive, not help them die. On the other hand, they're also taught to be compassionate and help alleviate suffering. So it's a real interesting issue. So we'll go on now to the next chapter, which will be chapter 27, which concerns the need in the American healthcare system. Oh, stop that. For reform. First off, costs are skyrocketing. Our costs in this country are the highest in the developed world. We are now approaching 18% of gross domestic product from the time that this book was written. We have, I don't know that figure of 15% uninsured still applies after the ACA, but a significant portion of our population is uninsured. The costs are rising far rapidly than general inflation, and all you have to do is look at some of the new drugs and procedures. I have a friend who just underwent an orthopedic procedure that the hospital, the bill for it was $80,000. And it was, just a procedure, and that isn't even the most expensive. A heart transplant's going to cost hundreds of thousands. Cancer treatments have gotten to the point where we're looking now at the distinct possibility of cancer treatments, the drugs, having a cost of $1 million a year or more. We already have drugs that have been approved that the estimate is $500,000 a year for the use of that. The rising costs have affected the ability to get insurance. ACA did a lot to alleviate that when it went into full production in 2014. But the lack of insurance is another issue, because when you don't have insurance, you don't try to get health care when you need it. You try to bull it out. The fact is, the United States is not getting its money's worth by any stretch of the imagination. The comparison is countries where we have universal health care. The buzzword term that we are now using here in the United States is Medicare for all, simply because Medicare is a system that is actually very successful. It's the most successful of its type of system. In other words, the population it covers of any of the developed countries in the world, actually, that are held up as models for universal health care coverage. Why are the costs going skyrocketing? Well, the United States costs in this country, a year ago, the estimate was about $3.25 trillion a year spent on medical care. This is the total outlay. The costs of government programs, the costs of insurance, the cost of co-pays, drugs, everything that's put into the system by anyone is considered part of that fee. And at times over the years, I can remember many incidents where attempts were made to control the costs. Their price caps were tried, that didn't work. We introduced the HMO system, that didn't work. We introduced the DRGs, which was supposed to standardize, that didn't work. They would work for a short period and then it starts skyrocketing again. Why are the costs rising? Well, part of it is an aging population. People over 65 consume about 80% of the medical care and costs in this country. That is expected because they're getting older. And there's short of just saying, okay, once you reach 65, you're on your own. There's nothing we can do about that, because of course now we are living far more than that expected 65 year of age average death from the 1930s. So we are seeing that go up. Another one is the cost of new drugs, the cost of new procedures, new diagnostics, new interventions. The ability now of intensive care units to employ technology to keep patients alive who, as little as 15 years ago, wouldn't have stood a chance. This is really this is another driver. Administrative costs are going up. There are many of these have to do with regulations, but a lot of them have to do with, quite frankly, sheer greed. Malpractice fears, malpractice insurance drives doctors out of business, or at least out of certain lines of business. Our first child, when she was born in North Carolina, our general practitioners took care of the birth, took care of the pregnancy, took care of everything through the birth, and then even did pediatric medicine as well. So they were also doing all the well baby checks and vaccinations and everything else. By the time our second child was born 3 years later, they had gotten out of that business because their malpractice insurance had skyrocketed to the point that they couldn't afford to deliver babies. And so we had to go to a specialty group, an OB/GYN group. So, but the other thing about malpractice is people are suing for everything. Fortunately, a lot of times that gets knocked down in court, but it's an expensive, time-consuming process. So doctors practice defensive medicine by delivering more care that isn't necessarily, than and over treating patients. Um, the There are also financial incentives like fee for service, that basically can be set in many ways, by the doctor's efforts to control this through cost controls, especially in Medicare, have not really worked. And another thing is the patients aren't sensitive to price. You go to buy a car, you're going to go shop around dealership after dealership, and you're going to find whatever car you want, um, and get and bargain for the best price. The last time we bought a car, I bought I my old car had finally reached the point where even my mechanic said it wasn't worth keeping, um, and so did some research, decided we wanted a Subaru Outback, and I went to a number of different sales sites, different dealerships, and finally found one that was willing to not only give me a reasonable trade-in value, but also to give me a good price, and offer me some really good terms. So, so price and term sensitivity is important there. That's why, you go buy your food at King Soopers or even Walmart, rather than Whole Foods. You're getting this ostensibly the same stuff for significantly lower price. But in medicine, you don't go doctor shopping. You don't try to find the cheapest surgeon, for instance. What you want is the best. And since you have, if you're fortunate, since you have insurance, um, you expect your insurer will pay for it. If you don't have insurance, then you still want the best because your choice is pretty unacceptable. Okay. All of these attempts, as I said before, um, we tried to go through limiting the number of hospitals and nursing homes, and we had the whole certificate of need issue, meaning that in order to build a new hospital, you had to show that there was a need in the area for doing that. Um, you take a look around, and the number of new hospitals that have been built in the last few years is pretty impressive. So then we had the DRGs. Managed care actually appeared in the 1970s. Um, Managed care, we'll get back to that in a bit, but managed care was had some issues. Um, so we continue to try and see what can be done about controlling those costs. Um, Health maintenance organizations appeared during the Richard Nixon administration, specifically in approximately 1970, um, providing both insurance and care through a network of physicians who may or may not be on salary, but who have agreed to basically take, maybe a little bit less or maybe a lot less for each patient. The quality of care came under fire in many cases because physicians were given a fixed total for each patient that was enrolled in this in the maintenance organization. And that fixed amount was what they got, no matter what the care was. And so there was a lot of concern about the quality of care that was actually going to be delivered, and actually was delivered. There were several major kerfuffles about that. Um, the There was a tremendous effort to deny care that they thought was unnecessary. On the surface, not providing unnecessary care sounds like a great idea. But when the financial incentive is in terms of you end up getting more if you're not providing care, because in effect, you're getting paid not to do anything. Um, this puts an ethical dilemma um, um, into the equation. Plus, limiting access to expensive specialists and expensive technological issues. Um, and the good part was preventive care. Well, Americans don't do well with preventive care for the most part. We like to live our lifestyle as though we can do anything we want, and all we have to do is go to a doctor and get patched up. Um, so, preventive care clearly is the way to go, but the problem is we don't start it early enough. Preventive care should start with the onset of pregnancy, or actually even before that. PPOs have participating providers who provide services at lower rates, and you pay a lot more for going into to a non-network provider. We still have a lot of those. Um, the the term drive-through delivery and drive-through mastectomy was an effort to prevent people from being sent home essentially from the hospital way too early. Um, the one of the things that happens is hospitals are expensive to operate. Their daily room rate is pretty outrageous, and so they would try to empty, since there were limits to what the insurers would pay the hospital for any sort of procedure. The hospital and had an incentive to send patients home early. And then we had people going right back into the hospital, sometimes with life-threatening issues. Gag rules were keeping people from talking about a number of things. And then finally, um, um, we started having lawsuits, people suing the HMOs for denial of care, sometimes suing after the death of a loved one, which of course pulls at a lot of heartstrings in the courtroom. Um, Meanwhile, and so prices began to rise. They basically lost the ability to manage the costs in any significant way. Rationing was tried. Um, the Oregon experiment with Medicaid was again an approach that in order to provide certain care, it had to go before a committee that would examine the data and make recommendations as to whether or not a specific patient should receive something. Again, the ethics of that are kind of interesting. Um, if you look at if you look at the Hippocratic Oath. Um, but it was an effort to limit services to provide broader coverage. So every expensive service in a cost-constrained atmosphere, or in a funding constrained atmosphere, means that other people can't get service. So it's again, it's a toughie. And So they did. They developed this list of services, trying to involve the population, and in making that, so that they could go back and say, when people complained, well, this is what was decided by you and your peers. Um, Looking at cost effectiveness, how many people could benefit, um, increases in life expectancy. Lately, we've been seeing drugs for cancer that come out. They cost they cost tens of $1,000s rather, for treatment to extend life by an average of 5 months. Well, that might be nice if it's 5 months until your daughter gets married, but I'm not sure what that's supposed to tell us. But the whole idea of rationing, of limiting the services available, and deciding that Joe Blow gets coverage, but you know Bill Smith does not. That's all. This uh, made people uncomfortable. But in effect, we have rationing. If you can't pay for your care and you don't go in, it's self-rationing, but it's rationing. It's not by your conscious choice that you don't have the money to be able to get that care. There's also the rationing by the insurance companies. So we have a number of issues. Other, and the other thing that goes on with rationing is, of course, you're putting value on human life, and that is a very slippery slope to start playing with. And you know, it is interesting. Um, I would not ever participate because, of course, when you look at valuing another person's life, what you're saying is that this person either deserves or doesn't deserve to be able to go on with their life, or is more deserving, and that puts a value on who they are. And that again is a very, very slippery slope, that we want to be careful of. And of course, meanwhile, we're not going to go through the discussion questions here. You can look at those if you want. Meanwhile, um, medical research is producing drugs and analytical tests and procedures and surgeries and technologies, all the time, that are extremely expensive and very much objectively, um, are advances in technology. Um, the or advances in medical delivery, but the costs are skyrocketing. So you might think about this particular first discussion question, examples from your experience or that you've observed in family or friends, the expensive use of the healthcare system. Um, and do you think the expense was justified? I've got a couple of those in my family. Um, and the outcome was the same, just a little slower. In one case, when my sister passed away, she was being kept alive mechanically. Um, and we went through quite a bit of discussion about whether or not she should have her have the machinery turned off, the life support system turned off. She was brain dead. Um, she'd already had so many heart problems that she had implanted defibrillator and a pacemaker. Um, and finally, and her husband um, was her closest relative, and it took a while for him to accept that um, that he should simply allow her to pass on into the next world, because she clearly had already. So we're going to go on now to the next chapter, which is chapter 30, which is about emergency preparedness. We're going to go down here, and this is emergency preparedness post 9/11. We've always had emergency preparedness, but emergency preparedness is an extremely broad term. 9/11 brought out the terrorism aspect, although we'd certainly seen terrorist acts in this country before that. But something, um, uh, but after that, it became a bit more of a priority to examine. Now, not just terrorist activities, but things like natural disasters, things like technological disasters. That includes terrorism, but a good example of a technological disaster in this country is the 1977 incident at the 3 Mile Island nuclear plant in southern Pennsylvania. You may have heard of it, but you certainly shouldn't have been around for that. But my wife and I were living in Australia when, well, it was 1978, I think, is when that happened. My wife and I were living in Australia when that happened. And we had her sister and my entire family, my mother, my father, my sisters, um, and their kids, and all of my cousins and aunts and uncles were living downwind from that site. So, and in Australia, we couldn't get any news. It was very, very frustrating. But the issue is that this was a disaster that, although could have been anticipated as possibly happening, nobody thought they could. We thought we had the controls in place. Didn't work. Technological disasters also include terrorism, such as the 9/11 attacks. Really, the way we approach these is similar, but of course it's going to be different. The problem with any form of disaster is the unpredictability. There are some that are fairly predictable. Hurricanes, we can track those, and we're getting much, much better. But we can track those all we want, and we can project where they're going to go and get people prepared ahead of time. Um, and then deal with it. Earthquakes and you know things like the forest fires in California that occurred last year, tornadoes, and terrorism are not predictable. We think we can predict earthquakes, and every time we think we can, we get shown that no, we're not quite that smart yet. We also think that we're working on predicting tornadoes, but again, we can't. We can only say the conditions are forming, that this can happen and give warnings. But a tornado happens so fast that when it does, there's little that anyone can do except take shelter and hope that they get there in time. Um, the um, the preparation comes in planning and being prepared to immediately put into place efforts at search and rescue, evacuation and treatment, and having supplies of food, water, and shelter, and to find a way to minimize the environmental hazards. This comes from things like the the destruction of the ability to have sanitation of water and so forth, and other sorts of things that come from the destruction of facilities that may have hazardous materials. The list of disasters is huge. It's not a job that is for the faint of heart. The recent example, well, 18 years ago now, um, is the World Trade Center attacks and the Pentagon attacks on 9/11. They, you know, the fact that 2,800 people died in the World Trade Center that we know of. It wouldn't surprise me if there were people that we don't know of for various reasons, because no one knew that they were there. But there were lots of problems. The fact that we got that many people evacuated from the towers before they fell was a victory, but we still lost a good 20% of those that were there, that shouldn't have. Um, the other thing is what's been in the news lately. We haven't done anything to protect the rescue workers from the long-term follow-ups of these things. This has turned into a political issue, um, and it's turned into something to really consider. Um, what is the social responsibility for people who risk their lives and their health to help their fellow human beings? I mean, there's no way to answer that um, in the negative that doesn't make you look pretty bad, which was one of the things that politicians were running into a few months ago. The public health functions um, are pretty obvious. We don't have to go through this entire thing, but you know the areas here are where we began to fall down. The mental health counseling, the surveillance of cleanup workers, etc. This is where we fell down in that. Hurricane Katrina is another example, wiped out New Orleans. And of course, more recently, we saw the Hurricane Maria and the damage it's done to Puerto Rico, and our complete lack of appropriate response on the part of our government to try to help the people on the island of Puerto Rico. Many things um, went wrong with that and continue to go wrong. But and this is really an important issue in terms of any natural disaster or any kind of disaster that affects people, is that there needs to be a framework in place for the follow-up, for the cleanup, for the rehabilitation of the area. There needs to be a plan for that, but the plan needs to be flexible because every single disaster is inherently different. The destruction of Puerto Rico was different from the destruction of New Orleans because they were different environments. Um, the destruction of the World Trade Centers in the middle of a big urban area, the effects really are much more widespread than just lower Manhattan. the there the and communication systems should be set up with emergency backups for everything in sight as well. And this is where we need to decide who is responsible. We have the Federal Emergency Management Administration, FEMA, um, under budget, understaffed, underprepared, and that's been the case ever since it was started. So we had to deal with populations that have been displaced and were not able to return to their homes ever. So there's a lot of that that's gone on. Um, we have to be prepared for every aspect. In theory, processes are in place, but in fact, we have the processes are paper processes. We don't have stockpiles. We don't have all the other things that are needed. Um, we can stockpile and we can get ready for a hurricane um, that that comes in, but we can't stockpile and prepare for an earthquake. We know they're going to occur. Everybody knows there's going to be a major earthquake in California. When? Where? How bad? We don't know. People make predictions and they don't happen. Same with tornadoes that go through and destroy whole cities, such as happened in Joplin, Missouri a couple of years ago. So we have a number of different things to consider in dealing with this. Their communication is critical, but even if we have things like the command structure, and we're looking at in our state and federal structure here, local authorities should take charge. They know the area. Excuse me. And they should take the lead, but they have to be trained. They have to be ready to go. They need to have a group of people that they can call on to mobilize immediately to provide the various responses they need. And you can have all the strategic stockpiles of supplies and medicines, but if you can't get it to the place, then it's just useful. Bioterrorism is an issue. There are a number of things, but I'm going to add to this. We talk about bioterrorism, but there's also emerging infectious diseases. And in the last few years, actually, since this book was written, we've had Ebola, we've had Zika, and we've had some severe flus in other parts of the world um, that have been a challenge to the public health infrastructure, and have suffered from lack of preparedness and lack of willingness to accept that the fact that people can contract a disease, and then by the time they're starting to manifest symptoms, they're already back home and spreading it. This is what's happened. This is what happened with Ebola. Fortunately, we were able to deal with it. We're looking at, to me, we're looking at a major issue with tuberculosis, especially since we have extremely resistant strains in India where people go all the time, and coming back to the United States. Fortunately, we're beginning to catch them, but it's going to be impossible to monitor everything. Zika is a good example. Um, Zika, we thought, originated in Brazil. Well, guess what? It did not. Zika is the name of a swamp in Uganda, in Africa, where the original virus was identified in the 1940s. And so Zika's been around, but it didn't go directly to Brazil from Africa. It ended up appearing in parts of Asia and in Micronesia in the Pacific, and then moving on to Polynesia, French Polynesia, again in the Pacific, before suddenly appearing in Brazil. So these kinds of things, this whole idea of preparedness for outbreaks of emerging infectious diseases known as EIDs, is a public health issue And our public health authorities should be and do pretty well collaborate with World Health Organization, but there's still the people in the World Health Organization are limited by their own knowledge, sometimes not very not very wide and already set in their ways. Bioterrorism agents, smallpox and anthrax. We've seen anthrax here with our own internal bioterrorism. Smallpox is one that scares the dickens out of a lot of people because even though even though we think we've eradicated it, what we have not done is maintain any sort of herd immunity among our humans. And even people like me who have been vaccinated against smallpox since we were kids and got revaccinated in in what now 40 almost 50 years ago when I was drafted, got revaccinated. That's it. I probably have no immunity to smallpox. And the fact that we've wiped it out means that no one's going to even get a low level exposure that would kick in the immune response again. So that's a major issue. Plague is another one. We haven't. We know plague is all over. Everybody is warned constantly. Don't play with prairie dogs, right? They carry fleas that carry plague. So leave them alone. Um, we have had, we talk about plague as being non-existent, but there was actually an outbreak of plague in Los Angeles in the early 1920s that really surprised people and was quite an interesting story. And of course, the hemorrhagic fever viruses, Ebola, Marburg, and so forth, are ones that we've seen in the news. Um, Surveillance is necessary. We look at ER visits. We get the reports that are sent to the CDC constantly about new diseases. Pharmacy records can be culled for what medications are being prescribed and what diagnoses are seen. We look at veterinary diseases since many of these are what we call zoonotic. In other words, they transfer to humans from an animal vector of some sort. Um, and of course, poison control centers. Um, we talked about smallpox already. So there are just a number of issues. We have problems with our with understanding, and the problem is that it's very difficult to be prepared for everything. So what we need is, excuse me, what we need is the ability to be flexible. Let's go on to the last chapter, and that is um, the the challenges of that we need to face. Lots of achievements in the 20th century: vaccination, motor vehicle safety, workplaces, infectious disease control. Lots and lots of things that we have done to make for a healthier society. But we're facing now a renewed threat from infectious disease, a huge threat from um, um, emerging infectious diseases and from resistance, antibiotic resistance. We have very little we can do about most viral diseases, though we know that viruses can also develop resistance to the antiviral drugs. Climate change, even though there's a lot of resistance to even believing in climate change, eventually the the people who scream that it's not happening will end up being marginalized when the right time comes, when things get bad enough. The problem is it may be too late by then too. We are looking at our aging population. We're also having a flood of young people into the marketplace. So their lifestyle-related diseases need to be thought about. But we really, the more our average age increases, the more the costs of um, of um, of of medicine, or the cost of the medical system in general will increase. Much of the issues today are based on human behavioral issues such as diet, exercise, um, consumption of substances like drugs, alcohol, tobacco, etc. Um, and we need to find ways of educating people to do that. We need the public health system. We spend a minute proportion of that $3.25 trillion, like 2%, I think, maybe 3% on public health. Public health has done more to extend human life than everything else in medicine combined. So, public health itself is where we should be concentrating a lot of our money, but that is going to mean the impingement on what people consider to be their rights. In many cases, the whole vaccination thing is about rights. Um, Disparities in health between various groups, not just the wealthy and the poor, but the Northern European whites and people of color, of any sort of color. There are disparities in that health that comes from the availability of health to them. So we need to look um, at how to we've had a system of what we call management by objective. In other words, what do we want to achieve and how do we get there? So we've had a number of these kinds of reports. We call it Healthy People every decade or so. Um, uh, Looking at success and failure in the promotion of health and in prevention of disease. Um, National goals need to be set by the people, in my opinion, because the government is not really in the best position to set those goals. And because the government constantly changes through elections and so forth, there needs to be a national consensus on these things. We've made a lot of progress over the years. I mean, but all you have to do is look at incidences of dietary related disease, of lifestyle related disease, and so forth, to see that we still have many challenges. We need to look at trying to really move all of our health toward a wellness model first. And this really means looking at people's behavior. It means looking at how we can help people not need intervention type medical care. Um, and the we had part of it was the managed care was supposed to promote wellness. It hasn't worked. One of the tools that we have that is coming in is a tool that is a two-edged sword. It's information technology. That is, how do we share information that has the probability of having a positive effect on public health. And this means up and down while still respecting things like HIPAA, privacy. It is kind of difficult, but we already through reporting requirements, we can track infectious diseases, and we can monitor those disease trends to find out if we happen to have an emergency situation. We have lots of databases, and we need to be able to, this needs to be able to make the information available to individuals because it is of public interest. Um, but we do have also have to be careful about our information systems because the amount of false information, you can call them lies if you want, because in many cases that's what they are. The amount of false information about medical issues on the internet is really astounding. And the number of sites claiming to tell you how to live a better life um, are proliferating, and many of them really are honest attempts to get people to change their lifestyles, to change their exercise and eating habits. And sometimes it's just absolute hogwash. So we have to recognize that the accuracy and reliability of some of the information on the web is very, very suspect, and people need to be encouraged to really be careful and investigate. Um, Biotechnology is really a broad topic, so I'm just going to touch on a few things. These advances in biotechnology come about by our better understanding of the cellular mechanisms by which diseases are occurring and finding ways of intervening in those mechanisms to ameliorate the disease, cure the disease, modify the organism, and so forth. We're looking at the issue of individualized medicine, meaning we'd have lots and lots of different approaches that we can use to treat what is diagnosed as disease X, but in patient Y, the cause might be something very different from other patients who have the ostensibly the same disease. Also, the doses required might be different. So there's lots of material now coming out that tells us that these broad categories that we call diseases can manifest themselves in many, many different um, um, ways in, in different patients. And biotechnology gives us the opportunity to do that. But the cost of these things is going to skyrocket because that means that every patient is treated as unique, which means a lot of information that we have to have about that patient, and and we'll see what else happens. There are also ethical issues that have been that have been dealt with, and legal issues over what it is that you can own of the human genome and other kinds of things. So it really is something that needs to be considered. Um, Education is going to be an interesting issue to deal with uh, for um, for this because these are complicated issues. So education is going to have to be carefully constructed to be able to reach the broad swaths of society that don't have medical education, but are perfectly capable of understanding what's going on, even if they don't cotton on to the details of how things happen. And we need to determine what our priorities are. That's something that we have a hard time with here because nobody wants, things to be such that their priorities are somebody else's. And we have that sort of problem as well. So I'm going to cut this off here. I don't know how long we've been doing this, but it's about to end. So here I will remind you. Let's go back to the module, week 4. You've got a discussion. The discussion is um, about the efforts to repeal or replace ACA and what you think can be done to improve the Affordable Health Care Act. You've got your assignment this month or this week is basically the same as assignment 1 in each week, which is to go through these chapters and give me uh, an assessment of what you've learned, plus your final assessment and the career integration part. Um, so I did record something very briefly yesterday for Monday. So what I want you to do is look at this, send me an email with the word Borneo, Borneo, in it to tell me that you've looked at this and listened to it. And if you have any questions, of course, you can email me. I'm sorry I won't be able to be at school tomorrow morning, but I have to be out. So anyway, I look forward to hearing that you've graduated, and I will look forward to you getting all of your work done so that we can get your degree to you as quickly as possible. Anyway, thanks for being in my class again. It's been a pleasure to deal with you one last time. So I wish you the best.